I'm Marilyn, an anaesthetic trainee here. I'm going to be working as a clinical fellow in intensive care when you guys become fully fledged F1 doctors. So yeah, feel free if you see me around, ask me any questions. Today we're going to talk about medical emergencies. I want this to be interactive, so I don't want to be doing all the talking. I do like to talk, but I want you guys to interact with me. If you have any questions, just stop me and ask. So the aims are for us to go through an A to E assessment of acutely ill patient. We're going to go through the initial management of some cases. These are real life cases that I've been involved with. And hopefully by the end of the talk you'll know when to escalate care and know your role as an F1 when dealing with acutely ill patients. So just introduction. So acutely ill patients require rapid but careful assessment. So these patients are likely to rapidly deteriorate if you don't initiate treatment when you find something wrong. So usually the initiation of treatment often precedes definitive diagnosis, but whilst you're managing these patients and assessing these patients, you're still looking for a diagnosis. And the aim with an acutely ill patient is to prevent further deterioration and stabilise the patient. In order to do this, you need to make sure that you get experienced assistance as soon as possible. In hospital cardiac arrest, in asystole or PEA has a survival rate of 10%. The reason why I'm only mentioning the PEA and asystole is because these patients usually have documented deteriorations in their physiology prior to arrest. And these are often treatable and reversible. So the aim is for us to recognise the decline early and hopefully provide early corrective management in order to prevent cardiac arrest. So we're going to go through the A to E assessment. So hopefully during your time you've already had a bit of exposure to doing this. So who wants to start? What does A stand for?
Airway.
Airway, great. And what are you going to do when you're assessing the airway?
Talk to the patient,
Yeah.
verify their airways completed.
Yeah. Anything else?
Listen out for any like sounds, like snoring sounds, which can
Yeah.
just like the airways partially.
Yeah. And I've got a little star of get help now. So what kind of things do you think will be under get help now? What would you be scared of? If you saw a patient and they've got airway problem, what are you going to be scared of? Yeah.
Like gurgling sounds, for example.
Exactly. Anything else? If they're not breathing, exactly. And what kind of action will you do? So if you find an airway problem, what are you going to do?
So we try and check a head tilt chin lift.
Yeah.
Holds the airway in place.
Yeah.
Use it to something.
Exactly.
Suction.
Suction, yep. Anything else?
Try and look for any obstructions, and if you mouth, if there's obstruction that you can take out, try and take it out
Yeah.
without trying to push it forward.
Yeah, exactly. So, I mean, I'm a simple person, so I've only put a few things on here. But so, yeah, look, listen, feel. It's simple as that. You're going to look, see if their airway is patent. Is there anything in their airway? Listen, as you said, if you hear any abnormal sounds, snoring, stridor, gurgling. If it's silent, you can't hear anything. And then you want to do the simple airway maneuvers, so head tilt, chin lift. And if you feel competent and able to put an airway adjunct, you might want to put a nasopharyngeal airway or a Goodell airway, because then that will free up your hands and you can continue with your assessment. And if you've got an airway problem, call for help early. That is not something you want to be dealing with on your own. And as I said, if the patient has got an airway problem, a lot of the times it does take up your hands, so you can't continue with the assessment. So you want to get somebody in there so you can continue assessing the patient. And what does B stand for? Breathing together. And what are we looking for when we're assessing the breathing?
Chest expansion, equal bilateral, trachea shifted over, thorax, a good air entry, SATs doing high oxygen.
Yeah. So you were saying something? Yeah. Yeah, great. So again, so this is not like our typical respiratory examination. We're not going to go through everything, you know, hands and inspection, palpation, all those things. You just want to do a quick assessment. So you're looking to see, are they using accessory muscles? Do they look tired? Are they in a tripod position? And then you're going to listen. Can you hear wheeze? Can you hear air entry, crackles? What can you hear? And feel if your differential potentially is a pneumothorax, you might want to do some percussion, but you want to tailor it to what you're seeing. You want to do a quick examination to give you some feedback. If they're tachypneic, you want to call for help. So if their respiratory rate is greater than 25, you want to call for help. A lot of times, even if a patient doesn't have a primarily B problem, the first thing that is going to go off is their respiratory rate. So that's an indication that your patient is becoming unwell. And obviously, if they've got respiratory depression, you want to get help. You don't want them to get to the stage where they completely stop breathing. So the action at that stage is putting on high flow oxygen. You want to monitor their SATs. The reason why I've also put monitoring ECG and blood pressure is because these patients are acutely unwell, and continuous monitoring is invaluable in patients that are unwell. So if they're in a place like ED and you can put the ECG, the BP, put it on, and then put it on a continuous, when it will just auto come on the blood pressure every 5 minutes. So you're getting feedback every 5 minutes. But if you're on a ward, you can just get an OBS machine and that put the SATs probe on, that will give you heart rate. You can put the blood pressure on as well. So you've done all that simultaneously, so you know what's going on with your patient. And obviously, if they get to the stage where they're not breathing, they're going to need to be ventilated. So you might want to get an anaesthetist when you feel like the patient is not improving. The investigations that you would do for breathing include ABG, peak flow if they're asthmatic, chest x-ray. So look at their previous chest x-ray. If they haven't had one, you can order a chest x-ray. So C stands for circulation, obviously. So what kind of things are we looking for in circulation?
Heart rate, blood pressure, fluid refill. Generally, they're areas that they look very pale and cold and clammy.
Yeah, great. So and what action would you do if you find a circulation problem?
Trying to establish IV access.
Yeah. Anything else?
Pick blood, fluids.
Yeah.
ECG.
Yeah, great. So so circulation, as you rightly said, we're assessing the pulse. We want to look at the rate, volume, rhythm, and character. Looking at the skin of the patient, look at the colour, feel their temperature. Do they have warm peripheries? Are they peripherally shut down? What is their capillary refill time? And then if they're tachycardic, above 120, you're wanting to get help at that point. Or if they're really bradycardic, you want to get help as well. And if they're hypotensive, you want to get help. And it goes without saying, if they don't have a pulse, you're going to start CPR, pull the buzzer, put out that 222 call, 4 twos, whatever. I don't know how many twos I said. 2222 call and get help straight away. You'd want to do 12 lead ECG. You can also look at the urine output because that can tell you how perfused the patient is, if they're producing enough urine. You might not have time to look at the fluid chart, but just have a look at the urine. Is it concentrated? Is there any urine in there? And then if you're inserting a cannula, at that stage you can take some bloods. You might want to also consider some cardiac specific bloods, so troponin, D-dimers, things like that you would want to take at that time. And then D is disability. I'm just going to run through this. So when we're looking at D, again, this is not a full-on neurological examination. In the acutely unwell patient, you don't have time to be doing reflexes and all of that. You want to do, if you are not really, if you don't know the GCS off the top of your head, you can just do AVPU, but I mean, we all have phones, so you can just look at the phone and do the GCS, because the GCS is invaluable in a patient that has a primary D problem, because, for instance, we look at it to monitor how the patient is doing. Patients that have neurosurgical problems, sometimes looking at the M score will decide whether or not we're going to send that patient to a neurosurgical unit. So it's really important that you get that first GCS documented if you can. And then looking at the pupils, are they equal reactive to light? Are they dilated? Are they constricted? And then if necessary, you can just look for some focal neurological signs. At this stage, is that a test? Okay, so we got up to E, which is exposure. So at that stage, you want to do a head-to-toe examination. You want to look for rashes, scars, bleeding. At that point, you can do your abdominal examination if necessary, measure the temperature. If they're hypothermic, do they need to be warmed? You will look at the OBS chart results, look at the cumulative results, the drug chart, fluid charts, everything at that stage, and routine bloods if you haven't already done bloods. And if they're a young female, maybe you want to do beta HCG. So after you've done your AT assessment, if your patient is stable, you haven't found any life-threatening causes, then at that stage you can then do your detailed history taking, go and look at the notes, and all the other things that you would normally do. So we're going to go through the cases now. So we're going to start with case 1. So this is a 65-year-old female. She's asthmatic and a smoker. She presents to the A&E department with a 3-day history of cough and fever. Following the ED investigations, a provisional diagnosis of severe CAP is made. And following the guidelines here, doxycycline is given and she's transferred to AMU. However, she hadn't received the comoxiclav, so the ED nurse hands over that the outstanding comoxiclav is to be given. So you are the F1 on AMU. So you review the patient shortly after the nurse administers the outstanding medications. Whilst reviewing the patient, she begins to report chest tightness and difficulty breathing. What will you do now? Yes. So you begin an ATE assessment and you ask the nurse to do a set of obs. So A, her airway is patent. B, she's got widespread wheeze throughout and her SATs are 90% on air. Her respiratory rate is 30. What do you think? What are you going to do? Okay, yeah. Anything else?
ABG.
Yeah, put some oxygen, yeah. ABG, yeah.
Get some help because of respiratory.
Yeah. Salbutamol nose. Okay, cool. Yeah, so you said all the things. So yeah, you want to start high flow oxygen. So as I said, you find something, you want to treat it. So you start high flow oxygen, nebulized salbutamol you could give because she's got a history of asthma, she's now got widespread wheeze, and call for help as you rightly said. So I feel like at this stage you wouldn't be wrong in asking for help. Even if that just be help from a nurse coming in to give you an extra pair of hands, but you've got a patient that is unwell, so you need some help from someone at this point in time. So once you've put the oxygen on, you can move on to C. So she's got normal heart sounds, her capillary refill's normal, she's tachycardic, her heart rate's 100, and her blood pressure is 98/65. What do you think about C?
We want to establish IV access.
Okay, make sure she has IV access. Do you think she has a C problem at this stage, or are you happy to move on to D? She's a little bit hypotensive, yeah. Put some fluids. So yeah, you wouldn't be wrong if you wanted to start some fluids, put some IV access. But even though she has got some abnormalities, she seems like she's relatively stable. So you can quickly move on to D. She is alert, and then you move on to E. You don't find anything when you do a head-to-toe examination. Her abdomen is soft, and her temperature is 37.2. So given that you've given oxygen, you're going to reassess her and see if the oxygen has made any difference. And you're still waiting for your nebulizer. So like in real life, it takes time to get things. Even though you ask for the nebulizer, it's not going to come immediately. So you can continue whilst you're waiting for the nebulizer. So now you reassess. Her lips are swollen. She's got widespread wheeze throughout. She hasn't had her nebulizer. Her SATs are 92, despite the 15 litres that you started. And her respiratory rate is still 30. So what do you think at this stage? Anaphylaxis. You guys are amazing, yes. So you're worried that she's having an anaphylactic reaction. So what are you going to do?
Stop medication.
Yep, stop the medication.
Check her doctors for any allergies.
Yep.
Ask her if she might.
If she can talk, yeah. What else? Exactly. You want to get help. So this patient is going to deteriorate rapidly. You want to get help. If they've got true anaphylaxis, it is an emergency. You need help. Okay, so whilst you've put out your call and everything, you're going to quickly reassess the patient, continue with your assessment. Heart sounds are normal, but her blood pressure has now dropped. Her heart rate is 110 and she's got warm peripheries. So we've already said what we would do at this stage, call for help, and we've already said what we thought the most likely diagnosis is. So anaphylaxis, just a quick thing about anaphylaxis, is a severe life-threatening generalized or systemic hypersensitivity reaction. It is likely with the following: so acute onset of illness with a sudden progression, and a life-threatening airway and or breathing and or circulation problem, and possible skin or mucosal changes. although these may not be present and they're not required for you to make a diagnosis. So the treatment, you already mentioned, stop the trigger, call for help. If the patient is in a position for you to lie them flat, you can lie them flat and raise their legs in order to increase their venous return, because they're going to have a massive cardiovascular collapse. So you want to make sure that you try and increase their cardiac output before that happens. Airway may need to be established quickly, so you want to get an anaesthetist. The anaesthetist wants to be there to get the best chance to intubate the patient if needed. They don't want to be there further down the line when they've now got all the angioedema, and it's really difficult for them to intubate the patient. You're going to apply your high flow oxygen, apply your appropriate monitoring, and give adrenaline immediately. So adrenaline is going to reverse the effects of the hypersensitivity reaction in anaphylaxis. So you want to give that adrenaline as soon as you made the diagnosis of anaphylaxis. Give the adrenaline, and that's IM adrenaline 0.5 milligrams. So in reality, what that means is 1 in 1,000 is this small ampule. You want to get a 1 ml syringe and draw up 0.5 of that, and check that is 1 in 1,000, because adrenaline can come in different concentrations, and then you give that IM. It works within 1 to 2 minutes, and you might need to repeat after 5 minutes if there's no improvement. And again, because they're going to have cardiovascular collapse, you want to give a fluid bolus. So just continuing the case. So the medical registrar arrives swiftly and agrees with the diagnosis of anaphylaxis, and they administer the adrenaline. Despite this, the patient deteriorates rapidly and goes into cardiac arrest. She is intubated during the arrest, and there is return of spontaneous circulation after 3 cycles of PEA. She is transferred to ICU on an adrenaline infusion. So why is there rapid deterioration in anaphylaxis? Okay, yeah, that's kind of it. But yeah, there's something else that I wanted you to say.
In shock.
Okay, yeah, they're going into shock. Why are they going into shock? Why do they get this massive cardiovascular collapse?
Widespread histamine release.
Yeah, vasodilation. Sorry, what did you say?
Widespread histamine release.
Exactly. So yeah, so it's basically just because of the pathophysiology. So it's a type 1 immediate hypersensitivity reaction, and it's triggered by the agent cross-binding of the IgE antibodies, and this causes a widespread mast cell degranulation. So you can imagine, like, all of your mast cells just releasing all the vasoactive substances that they have. That causes widespread vasodilatation, and then you get that cardiovascular collapse, and you get that severe systemic response. So, and again, it's affecting your airway, it's affecting your breathing, it's affecting your circulation, everything. That's why you get rapid deterioration of the patient. And why do we give adrenaline? Why is it so important? This is going back to physiology. So.
It affects the sympathetic nervous system, causes vasoconstriction.
Mm-hmm.
Peripheral.
Yeah. Anything else?
Positive inotrope.
Yeah. Okay, so yeah, sorry, what did you say?
The positive inotrope as well.
Yeah, exactly. So again, so going back to the physiology, it's because adrenaline has adrenoreceptor activity. As you said, it works in your sympathetic nervous system. So that causes peripheral vasoconstriction. That's counteracting the vasodilatation. Also, the beta adrenoreceptors, that gives you positive chronotropy, also works in the airways to counteract the bronchoconstriction. And also it actually can act directly on the mast cells to stop them from releasing more histamine and leukotrienes and all those things. However, adrenaline has a short half-life, so that's why we have to give repeated doses, because all the histamine and all the other things are around for longer. So you need to make sure you keep giving the adrenaline so it can have these effects. And what are the elements in the emergency treatment? What are the other elements in the emergency treatment of anaphylaxis? So we said the adrenaline, that's the most important. Yep, antihistamine and yeah, so steroids. So do you know the doses?
10 milligrams.
Yep, you have chlorophenamine and
200.
yes. So, and again, like, this is not a test. If you don't know, you can look it up. We've all got phones. Just look at the guidelines so you make sure you're doing the right thing. No one's no one's going to think, oh, you don't know what you're doing, just check it. Even when I know what I'm doing, I always check things, especially in an emergency, just to make sure you don't make a mistake. So chlorphenamine, 10 milligrams, and that's a H1 antagonist, so that will overcome the histamine induced vasodilatation, bronchoconstriction, and hydrocortisone, 200 milligrams. Although it takes a long time to work, it's really important that you give it as soon as possible so that it can have its effects and prevent the biphasic response. And also you can give salbutamol just as an adjunct. It doesn't actually reverse the anaphylaxis, but it can help with patients that have severe bronchospasm. And what can aid later diagnosis in uncertain cases?
So IgE.
Yes. So the mast cell tryptase. So you want to take the sample as soon as you've given that adrenaline. You take, or if you've got extra hands, you can get somebody else to take it. But make sure that the patient is being treated before you start taking the mast cell tryptase. And then you take your second sample, ideally within 1 to 2 hours, but if it's not possible, make sure that you take it within 4 hours. And then you want to get a baseline third sample at 24 hours. Other management, they're not necessarily things that you need to remember, just interesting facts. So if a patient has adrenaline-resistant anaphylaxis, that may be because they're on beta blockers. And in that case, we would give glucagon, as that is the antidote to beta blocker overdose. We'll give, and glucagon actually works it has a chronotropic and inotropic effects, but it works unrelated to the beta receptors, so that's why we give glucagon. Patients that have hereditary angioedema, they may present with symptoms that are similar to anaphylaxis. However, the history will be different. There won't be a trigger usually. They won't have urticaria usually, and usually they will not have any hypotension. And it's more slow progressing than anaphylaxis. And obviously they will have a history of this because it usually presents in childhood, gets worse in adolescence, so they would know that they have that. And in those cases, you'll give them C1 esterase inhibitor concentrate. And most patients actually have their own. So when they have an attack, they come to hospital with it. But if for whatever reason they don't have it, you can give fresh frozen plasma because it also has C1 esterase inhibitor in there. So continuing with the case, she's extubated the following day and stepped down to the ward the day after. The mast cell tryptase confirms anaphylaxis. Allergy clinic on discharge confirms penicillin as the allergen, and the MHRA yellow card is completed at some time during her stay for an adverse drug reaction. So, does anyone have any questions about that case before we move on? It's all self-explanatory.
I've got a question.
Yeah.
Because I've never dealt with proper anaphylaxis, so just for all our benefit, how quickly did it all unfold?
So I was called in at the stage where the patient was in cardiac arrest, but it was a quick. When I got there, the med reg was like, "Oh, we've given adrenaline. We've realised that she's in anaphylaxis." Then she went into cardiac arrest, and so it was very quick. But
so you're on the anaesthetic team, were you?
I was on the anaesthetic side, yeah.
So from your perspective, you would have rather put up 2222 call earlier.
Yeah, it was. That was like the worst intubation I've ever done.
Right.
So I would have preferred that the patient was called like I was called earlier. Yeah.
I think that's probably the biggest lesson, isn't it? Like, I don't think anyone's ever going to complain if you put out 2222 in anaphylaxis because it's so little time.
Yeah.
Like, even if it turns out to not be such a severe reaction.
Yeah,
right?
exactly. And from an anaesthetist point of view, you want to have the best chance of intubating the patient. So you would rather come earlier knowing that they're getting airway compromise. Okay, I'm going to intubate this patient, as opposed to they're now in cardiac arrest and it's like awful. So yeah, if that happens, please call early. We won't be angry. So case 2. So it's a 58-year-old brittle asthmatic with multiple attendances to A&E in the last year and previous admission to ICU 4 years ago. He's currently on Accuhaler, which is fluticasone and salmeterol, Montelukast and salbutamol PRN. He's brought in by ambulance with a 1-day history of increasing wheeze, chest tightness and cough. He's given an air by the ambulance. On arrival to ED, he's unable to talk in full sentences. He's in a tripod position. His respiratory rate is 30, heart rate 120, peak flow is 220, his best is 450, and his ABG on admission on 2 litres nasal cannula is pH of 7.49, PO2 of 11.7, PCO2 3.7, bicarb of 27, and lactate of 1.9. How would you grade the severity of his exacerbation of asthma? This is a little bit of a difficult question, so without looking up the guidelines. So don't feel severe. Okay, so yeah, we'll look at the guidelines. I always look at the guidelines to make sure that, I mean, you can kind of get an idea, as you said, severe, but you want to make sure you look at the guidelines. So a moderate acute asthma attack, he doesn't really fit that. His peak flow, for that you have increasing symptoms, and your peak flow is greater than 50 to 75% of your best or predicted, and you have no features of acute severe asthma. However, he does have features of acute severe asthma. His peak flow is 33 to 50%. His respiratory rate is greater than 25. His heart rate, what was his heart rate? I think it was 110. 120, so yeah, greater than 110. And he can't speak in full sentences. So he's got an acute severe asthma attack. At this stage, he doesn't have any features of life-threatening asthma, which are listed there. So with regards to when you're dealing with a patient with acute asthma, just look at the BTS guidelines and just see. And I think in this hospital, if you're going to be working here, we have a pro forma that you can see in A&E, and it's got the guidelines on it. And it's also got the charts for predicted peak flow for age and height. So if they don't know their best, you can just look at the chart. So he initially improves with back-to-back salbutamol nebs, ipratropium bromide, and prednisolone, which is administered in ED. He's transferred to AMU on 2 litres nasal cannula with ongoing treatment prescribed. 4 hours later, you are called to the ward as he becomes breathless, wheezy, and is desaturating. The nurse has helpfully done some obs for you before you arrive. His respiratory rate is 35, his SATs are 90% on 4 litres, his heart rate is 115, and his blood pressure 136/86, and he's apyrexial. So you're going to begin your A to E assessment. Just looking at those obs, what are you thinking already?
Start on high flow oxygen.
Mm-hmm.
Call for help.
Yeah. So yeah, rightly so. You're looking at these obs, you're thinking, I've got an unwell patient. You're going to have a look, make sure the patient is still breathing, and start your assessment. But in your head, you're thinking, I need help as soon as possible. So you might just go into the room, realise, okay, yes, this patient is unwell, ask the nurse to go and call your med reg as you continue doing the assessment. But as you rightly said, when you look at these obs, you're starting to think that this patient is going to be unwell. So you begin your A to E assessment. So his airway's patent, but he's unable to talk in full sentences. He has widespread expiratory wheeze, he's sitting in a tripod position, and his peak flow is now 150. Oops, I've given you the answers. So what are you going to do? If you can't read that quickly, hopefully. You've already said high flow oxygen, yep.
Nebs.
Yep, you want to give him nebs. ABG, you want to do ABG, yep. Yep, put the SATS probe on. So yeah, good. So as we said, start high flow oxygen. If you put salbutamol and ipratropium together, it's actually physiochemically stable. So you can just put it all in one neb and have that together. You want to do an ABG, apply the monitoring. As I said, even though this is a B problem, get that. The SATS probe is going to give you the heart rate. You're going to get the blood pressure as well on, so you know how your patient is doing. And then if they haven't had a chest X-ray, you might want to go and order chest X-ray or look at their previous chest X-ray and just see what was on there. So once you've begun giving the treatment for B, you're going to move on to C. His heart sounds are normal, capillary refills normal, he's got warm peripheries, no peripheral edema. So you'd want to do a 12-lead ECG. The reason being, even though he doesn't seem like he has a C problem, he's got wheeze, he's got a breathing problem, that could also be secondary to something going on with his heart. So you want to do a 12-lead ECG and make sure that that's not the reason why he's suddenly deteriorated. There could still be something else going on. Pathologies can coexist, it's not always just one pathology. So you're asking the nurse to do that, you move on to D, he's still alert, and you move on to E, his abdomen is soft and tender, there's nothing to find on E. So you're joined by the critical care outreach nurse who reviews him whilst you run the ABG. So you come back with your repeat ABG, which was on 8 litres because he was receiving NEPs, and his pH is 7.37, his PO2 is 8.5, PCO2 is 5.4, bicarb 26, and his lactate is 2.1. What do we think about this ABG? What is concerned? His CO2? Yeah. So what about his CO2? Sorry, you said CO2.
So he's no longer blowing off the CO2, he's starting to retain.
Okay, so yeah, it's normal, so that's worrying. We don't want it to be normal, yeah. And so I heard somebody else saying something.
He's tiring.
Yep, he's getting tired, exactly. Anything else on his gas that you're worried about? So just like the specific things. So we said CO2, hypoxic, exactly, yep. Potentially, yeah, because he's getting tired now. Anything else? Yeah, exactly. His lactate is starting to go up. And why is his lactate starting to go up?
Just for my benefit.
Yeah.
Anaerobic.
Yeah, exactly. So he is now starting to get hypoxic. So there's tissue hypoxia, and so he's starting to respire anaerobically, and so then he's producing more lactate. So yeah, even though it's only 2.1, but in your brain you're going to start thinking, okay, I'm expecting that. Now he's becoming more hypoxic. Even looking at the O2, you're thinking he's becoming.
It's quite a delayed marker as well, isn't it? Like
Exactly.
So if it's already there, you know things are going on.
So okay, which risk factors does he have for developing near fatal or fatal asthma? This would require you to remember what I said in the beginning. But can you think of any?
Previous ITU admission.
Yeah.
Brittle asthma.
Yeah.
And maybe if he has multiple admissions,
Yeah.
probably it's not well controlled.
Exactly, yeah. So yeah, he's a brittle asthmatic. He's had multiple attendances to ED in the last year. He's had a previous ICU admission, and he's currently on triple therapy. So he's got advanced asthma as well. So those things make you think that he's already got risk factors for developing near fatal or fatal asthma. Even when he came into the hospital, he already had those risk factors. And this is just a reminder of the asthma treatment. So he's currently on the stage here where it says additional control of therapy. So he's quite high up on the asthma treatment ladder. So his asthma is not really well controlled. So the critical care outreach nurse is concerned, rightly so, and she calls the ICU reg, who suggests magnesium, and they will review the patient as soon as possible. Why does caution need to be taken when you're giving patients magnesium? Pardon? I didn't hear what you said, sorry.
Can't magnesium be toxic?
It can cause toxicity. It can. If you give it in high doses, it can.
Neurological problems.
It can. Yeah, there's in magnesium overdose. However, what about if you just...
Cardiac.
Pardon? What did you say?
As in cardiac, you need to monitor it.
Yeah.
Does it affect their calcium?
Okay, I'll tell you. So all of those things are right. Those are all like in overdose, yes. But when you're giving a one-off magnesium in a patient, you need to make sure it can cause a powerful vasodilatation. So you need to make sure that that the patient is not hypovolemic or septic. Just be really careful because you don't want them to then go into hypovolemic shock.
BPS says it has to be a senior
Yeah.
decision.
Oh yeah. Obviously. So yeah, I've put the ICU reg as the person who suggested this. So usually, if you've got to a stage where you hopefully have already called for help, but the person who's going to be deciding whether or not you start magnesium is most likely the medical registrar, the ICU registrar, or your consultant. So, I mean, you can suggest it, you'll look really clever, but you shouldn't prescribe it until someone senior has decided that that's what the patient should have. What other therapy can be started on the ward? Do you know of any other therapies that potentially for really severe asthma? Yeah, what did you say? Yeah, so you can give IV aminophylline. Yeah, so the evidence for this is actually quite poor. But if you're getting to the stage where the patient's got severe asthma and is progressing to life-threatening asthma, then potentially after senior decision they might decide to start IV aminophylline. And with that, you would give a loading dose and then a continuous infusion. However, just be aware of patients who are already on oral theophylline. So this might be Filocontin continuous if you look in their drug chart or you look on their past on their drug history. So just be careful, because then they're more likely to get toxicity if you accidentally give a loading dose to a patient who's already on oral theophylline. And you would check the blood concentration before you start an infusion in a patient who has already been taking oral theophylline. So this, just to remind you that after you've instituted all of your therapies, especially in a patient with severe acute asthma or life-threatening asthma, you want to assess the response. So are they becoming less distressed? Are you getting improvement of their respiratory rates and their heart rates? Are they now able to talk in full sentences? Can you now actually hear more air entry, air movement? That might mean you hear more wheeze, but that's good because now they're getting more air in. And then make sure that you repeat the ABG within 30 minutes if you're not seeing any response. So little or no response, repeat that ABG, because that ABG is going to indicate whether or not potentially that patient might need to go to intensive care or something like that. So the ICU reg arrives and examination is now as follows. The chest is quiet, there's no wheeze, respiratory rate is 28, SATs of 92 on 60%. Is he improving? No, altogether, no, he's not improving. And why isn't there any wheeze?
He's not breathing.
So he's breathing, but
Chest.
he's got a silent chest. Yeah, but why is there no... Why is it? Like, he is breathing, and it sounds quiet because...
It's just not really entering into the lungs.
So yeah, so okay, exactly. So he's not getting enough tidal volume. He's now really tired. His respiratory rate is going down, not because he's improving, but because he's getting tired. He's on 60% and he's only saturating 92. This is a really sick patient. So at this stage, further, he's now only responding to voice. His GCS is E3V5M6. Where should this patient be managed? Intensive care, exactly. So he's taken to intensive care for further management, but he has a respiratory arrest on arrival to the unit. Fortunately, it's brief and he avoids intubation. Just for clarification, do you guys, just tell me if I'm being annoying, do you know the difference between respiratory arrest and a cardiac arrest? Not sure? Okay, yeah, so fine. So if you in a respiratory arrest, you still have cardiac output, you still got a palpable pulse, but the patient is not breathing. And in that patient, obviously, they're going to become extremely hypoxic and then have a hypoxic arrest. So what you want to do is, in those patients, you might want to do a tube-bag technique at your stage and ventilate the patient. Obviously, hopefully you've called for help and some help is coming immediately, and then they will ventilate the patient and hopefully prevent them deteriorated into a cardiac arrest. And cardiac arrest is full-blown loss of output, and then you would do CPR. But sometimes, actually, even in respiratory arrest, because the patient is not breathing, you might have a very thready pulse. So sometimes patients still do have a few cycles of CPR, and there's nothing wrong with that until you get their ventilation back. So again, this might be difficult. This is just added stuff, so don't worry if you don't know this. What further management can be offered in ICU? Specifically for asthma is what I'm talking about. Not really, but some kind of infusion. You're on the right lines. I've heard somebody say it. Yeah, you can give a salbutamol infusion. Anything else? You might not have heard of this stuff, though. It's okay. So the things that we can do in intensive care, we can give IV salbutamol, we can give sevoflurane, that's an anaesthetic gas which causes bronchodilation. We can give ketamine infusion, that is an NMDA receptor antagonist, and it also causes bronchodilation via direct action and sympathomimetic effects. And if the patient gets to the stage where they need intubation, we can offer mechanical ventilation. So that's the end of that case. Does anyone have any questions about the second case? No questions? Okay. So case 3. This is the last case. So this is a 28 female with sickle cell anemia. She's on the medical ward on day 2 of her admission for a painful crisis. She has no drug allergies. She's on regular penicillin before she came into the hospital, nothing else. Ongoing issues with pain, so she's got a morphine PCA, and she's been reviewed by the pain team earlier during the day, and they actually increased the morphine PCA bolus to 2 milligrams instead of 1 milligram. The nurse calls you as she is unrousable. And you're going to start your A to E assessment. So A, hello, can you hear me? There's no response. You can see that she's moving air, but you can hear intermittent snoring noises. What are you going to do? Yeah, head tilt, chin lift, exactly. Anything else? Call for help, yes. Call for help. Okay, so you're worried she's got an airway problem. So yeah, you can do head tilt, chin lift. And also, when you've got an airway problem, you want to put oxygen on as well. You can insert an airway adjunct. So if you feel like you can put an NMPA in or a Goodell in, that will free up your hands, so then you can move on whilst you're waiting for your help. Or you can just ask one of the nurses to come. Are you competent in airway manoeuvres? They can just hold their head tilt, chin lift. But what you want to make sure is that once you've done your manoeuvre, am I now seeing air entry? Has the snoring sound gone? So there's no point of just doing it and then they're still snoring because you haven't relieved the obstruction. So make sure that you've relieved the obstruction and then you can move on to the next bit. So whilst you're waiting for help, you continue your assessment. So you've managed to clear the airway, you've got a Goodell in place. The chest is clear, her SATs are 97% on 15 litres, which you placed in after you've done your head tilt chin lift, and her respiratory rate is 8. Anything at this stage that you were thinking? You're thinking overdose, okay. And so you're going to move on again to look at the chest. So you're thinking in the back of your head, this potentially can be opioid toxicity, but even though she's got a respiratory rate of 8, you've already asked for help. That's coming. There's nothing more you can do. You put the oxygen on, so you can go on to your C. Heart sounds are normal. Capillary refills normal. No peripheral edema. Heart rate, blood pressure normal. She's got an 18 gauge cannula, which is green cannula connected to morphine PCA. So you might want to disconnect that at that point. And so yeah, and then you do her GCS. She is E2, V2, M4, and her pupils are equal and reactive to light. And don't ever forget glucose. Her glucose is 5.1.
In B, would it, if you had someone there who could help you, would it be worth like ventilating her with like a bag valve mask because her respirate is low? So what would make me ventilate a patient? She's saturating okay on 15 litres. So despite the fact that she's got a low respiratory rate, I'm happy that she's getting enough oxygen. If she started to desaturate, then obviously you're going to go back to B and then start bagging her. But she's stable enough for you to quickly continue. You know your help is coming. Hopefully it's senior help. So you just continue, and maybe you'll find something that will help you with the diagnosis before they get there. And again, with this GCS, you want help to be coming, so you make sure that you've got help coming. What are you thinking? You've already said opioid toxicity, rightly so. So what drugs should be given if you're thinking of opioid toxicity? Exactly. Do you guys know the dose of naloxone? So you can look it up, but typically you would give 400 mics IV or 800 IM if you don't have any IV access for whatever reason. Say they come into ED and you think they've taken an overdose of heroin or whatever, you can just give them IM. And you want to repeat that after 2 minutes if there's not an adequate response. Why do you think you need to keep repeatedly giving the NOx? Exactly. So it's got a shorter half-life than the opioids, and so typically most times if they've got a true opioid toxicity they might actually need an infusion as well. Okay, so we continue with the case. Your registrar arrives and naloxone is administered. There's no response after 800 micrograms IV and her GCS is worsening. It's now E1, V1, M1. So what are you thinking? Okay, yeah, you want help, you want anaesthetic help. So yeah, you could put up a 222 call. Good. So the ICU team is called and they intubate the patient on the ward. What else could be going on? What do you think?
Something to do with the signal cell.
Yeah, exactly. So yes, it could be it can be completely different pathology. Although she was on the morphine PCA,
I mean, it's very rare for a patient to get opioid toxicity on a morphine PCA because it has a lockout time, so it doesn't really fit. So just one thing to be aware of, assessing an unconscious patient is very difficult. It's not usually an easy diagnosis because the main thing you want to do when you get to that patient is maintain the airway. If they're unconscious, make sure that they're maintaining their airway. And you need to frequently reassess their GCS. As I said, sometimes changes in GCS will indicate that patient needs to go to a different centre or have neurosurgical intervention. So you need to make sure you're monitoring. And these things can happen quickly. So you want to be looking at their pupils, assessing their GCS. But once they're stable, you want to examine the patient carefully, see if you can find anything on your examination that's going to point towards a diagnosis. Make sure you've done your BM because that is an easily reversible cause of a patient being unconscious. But other important bloods include taking the FBC, electrolytes, toxicology, if that history shows you that you should be doing that. And a history is important. Find out who was with the patient before they went unconscious. Was it the nurse? Was it a paramedic? Whoever it was, speak to that person directly. Maybe you need to call them on the phone if they've come in from home because the history is invaluable. It will help you to get towards the diagnosis. If you're suspecting that they've got meningitis, make sure you give IV antibiotics quickly, or any CNS infection that you think they may have, give antibiotics. Have they got a history of epilepsy? Are they post-ictal? Could this be a non-convulsive status? That is very difficult to diagnose. So you look at their eye movements. Is there something, do their eyes not look quite right? Sometimes people are not thinking of these things. So if you've got that in the back of your head that, oh, maybe it could be that, say it to your registrar, they may be really grateful for that. If the cause of coma is not immediately evident, then they may need further investigation. So like this patient, they had to go for a CT brain. And you do that once the patient's completely stable, obviously. If they've had to be intubated, they go for the CT brain. And when they're stable, then you can do a lumbar puncture as well if you're thinking that might help your diagnosis. So following intubation, she's taken for a CT brain prior to transfer to ICU, and her CT brain showed a large intracranial hemorrhage. So the point of this case was just to remind you that even if you think you found a cause of the patient's deterioration, there can always be coexisting pathology. So make sure you don't stop looking, keep looking. Especially in this case, it's so easy just to blame it on the morphine and keep giving naloxone, but she wasn't improving, so they made sure they got the CT head and they found out what was going on. So that concludes all the cases. So I hope from this talk you know to ask for help early. Remember that you're doing A to E assessment for any acutely unwell patient. I mean, you can even practice this just whenever you're called to see a patient. If you get into the habit of doing an A to E assessment, when you do see that patient that's extremely unwell, it will just be like second nature. You will know what to do. So I remember when I was at F1, I used to always do A to E assessment, and people just laugh at me like, "Why are you writing A to E assessment when they asked you to put in a catheter?" But I just kept doing it so that I would be good at it when I got to a patient that was really unwell. And also remember to stop when you find a problem. So there's no good of being like, "Oh, the SATs are 90, let me go on to C." SATs are 90, they need oxygen. Get the oxygen on. Once the oxygen is on, you've got your monitoring, you've got your SATs on, you can see, okay, the SATs are improving, let me go on to C, and then so on and so forth. And reassess after an intervention. Some interventions take time to make a difference. So if you've given a neb, you want to wait and see, is the neb, has it made any difference? Can I hear air entry now? Is the wheeze decreasing? And just keep it simple and you'll be good at F1s. Thank you. Any questions?
I've got a question actually about lactate.
Yeah.
So you know we said that when the lactate was high, it was because the patient was hypoxic. If you ever see a high lactate, is the patient always hypoxic?
No. So there's different types of hyperlactatemia. So you can have a type A or type B. Type A is usually due to tissue hypoxia, and type B can be due to increased production, inability of your liver to get rid of it, different acids and things like that. So, I mean, you need to assess your patient and see the reason why have they got high lactate. It's not always due to tissue hypoxemia. So, that answers your question. So just make sure you look at your history. Where is this lactate coming from? It doesn't always mean that it's because they're hypoxic. Any other questions? No. Thanks, guys. I hope you enjoy the rest of your day.